Wonderful talks I've heard today, so hopefully going to liven it up and maybe we can have a little bit of laughter because, you know, hypertension is real funny. That's a joke, boy. Y'all are going to be beating me today. Just in disclosures, I was part of the NHLBI risk assessment work group. I was part of the JNC 8 panel, and I must tell you, I was also part of the minority report that some of you may be familiar with that was with that. I'm currently part of the evidence rating committee for the ACC AHA hypertension guidelines that'll be basically released next week. So here's kind of where we are. I have no financial disclosures. What I'd like to talk about a little bit is just kind of with you, talk about the population risk of elevated blood pressure, the evidence and impact of lowering elevated blood pressure, and where do we go with target blood pressures? As we're all sitting here and you're practicing with your folks, where do we go? Where are we going to treat that blood pressure to the direction? I'd like to start out kind of a southern type of part that we're right here. This is not particularly the South, but if you see Roosevelt right there in the middle, this is at the Yalta Convention, and the decision was, well, we're trying to decide up how we're going to divide up Europe after World War II. We kind of saw where the consequences were going to go, so we're sitting right there and to do it. It's always fun to look at Roosevelt here, that he has he was smoking a cigarette and seemed to be kind of enjoying. Y'all figured out how Europe got divided up in this. So we're thinking about how this might turn around and look. Well, just a few weeks later, here it came out. And so the statement out of the newspaper, it came out of clear out sky. The president's physician says, this man had a stroke, and there we are there. So it was a total surprise. He was just dividing up how Europe was turning around and looking. So maybe it's not so much of a surprise. At D-Day, Roosevelt was having a systolic blood pressure of about 240. He was elected with a systolic blood pressure of 200, and right at the Yalta Convention where that photo was taken, it was back up at 240. And the story was that this would also be something that he would get up to 300 sometimes, and this is where his blood pressures are. So was it totally out of whack? What would you think about some of your patients that were walking in with these types of blood pressure levels? Well, where does the southern part come in? Well, this is a slide from the 1950s. In the 1950s, the U.S. Geology Society went door to door and was looking by county all throughout the United States, looking for a fountain of youth, looking for a safe water source. And you say, well, why would someone do that? Well, if some of you have been to Warm Springs, Georgia, I'm probably very familiar with it. Is anybody from Warm Springs, Georgia? Okay, that's good, so I can talk about it. Okay, anyway, Warm Springs, Georgia, here is a man with polio. Here's a man with elevated blood pressure. He would go to Warm Springs, Georgia and say, I get in the water and all of my woes are fit. My health is perfect. I am in great shape. And so that message got brought across, and they said, hey, let's look to see if we can find this fountain of youth. Let's see if we can see if it's something in the water that makes this man feel so good. It was actually a girlfriend in Warm Springs, Georgia that made Roosevelt feel so good. But that's another story. But here it was. And so here we have these wonderful high rates of disease. And what we found was not the fountain of youth, but we found this contiguous group of counties that began at the Virginia-North Carolina line carrying through southeastern Georgia, known at that time as the Enigma of the Southeast. These are the rates of some of the highest stroke rates in the entire world. So we knew that in 1950. So 50 years later, how are we doing? Well, now it's the rest of the South, so this can be the Southern Medical Association's calling card. Here we are. It's the whole South. You've all got problems. Wherever you are, you have a big problem with stroke in your particular area, and it carries through. Well, a few years ago, a good friend and colleague, Mickey Alderman, who's up at Albert Einstein University in New York, they did a paper in New England Journal of Medicine and said the problem with stroke mortality in the United States is the people from the South coming up here and having their strokes. If we could keep the Southerners out of New York City, we wouldn't have such a problem with stroke. Well, that kind of hurt my feelings, and I said, well, let's see if this is true. So we did a little study looking there a few years ago and basically asking the question, and you can answer the question too, were you born in the South? Simply right there. You know where you found it, were you born in the South? I was. Some of you weren't, and you're going to be smiling in just a minute, and some of you like, my mother and father chose to give me birth here, so this is what you see. And these are proportional mortality ratios. That's not important, but just think about this. If you're above the line, like I am, you're screwed. And if you're below the line, you've got this wonderful benefit about just not being born here. But look at this. This is South Carolina. I wanted to make it personal. And then this is the Southeast, and you're no better than I am. So this is where you're born. So what might be playing that type of a role? Well, the other piece of this that we found is I got a greater risk, okay? And this risk is like I have another cholesterol, some kind of elevated cholesterol that's making my risk. That's the magnitude that's difference. What is really amazing is look at what happens for those of you that were not born in the South, that are right here. The Caucasians, you basically have about a 25% less risk. That's a pretty good pill to take that I don't have to have it. If you're African American, 50% less risk, just don't be born in the Southeast. That's it. Just don't be born in the South. This is kind of where it is. And so we thought, well, a good recommendation would be to round up all the pregnant women and in the South and go let them be born somewhere else. Probably go back up to New York or whatever it's going to be. Clearly, that's just kind of not a part of it. So it must be something else playing a role. Well, maybe it's our stroke neurologists are really not that good. Maybe you have a stroke in the South and you die. Well, what we found here, this is doing some work, again, from that similar type of study in which we compared ourselves, these are all Caucasian men, compared ourselves with Rochester, Minnesota, which is the Mayo Clinic cohort that we had, and this is New Haven, Connecticut, and a cohort at Yale that they were doing, and we compared ourselves. Well, we're having more strokes. We have more strokes in the South. You already knew that. You didn't need to come here and hear this. You already knew that. You live it every day. But what we thought was a little bit new is we have our strokes about 10 years earlier than the rest of the folks. About 10 years earlier. So you're looking at me. I'm 63 years of age, but I'm living like a 73-year-old in Minnesota in that thing with regards to my stroke risk. About 10 years greater risk. Actually, just for fun, if you have a stroke, you ought to be in the South, because we have lots of practice and we do a lot better than the other places do with regards to case fatality rates. Bringing all this together and looking at this, we calculated a population attributable risk for hypertension. And this is what's phenomenal, we think, that's here. If we look at white males, it's about 23%. So interpreting the population attributable risk, that means about 23%, 1 out of every 4 deaths that occur in white men is due to blood pressure. Said in a more positive way, if we were able to control blood pressure, we could reduce the number of deaths for white men by 25%. Look at it for African American men. 45%. This is saying 45% of the deaths that occur to African Americans in the South are due to one risk factor, elevated blood pressure. And thinking of this part, one risk factor, and can we do something about it? And this is another part. These are survival curves, and I'm kind of going with something. I'm kind of saying things that you probably already know, I imagine. These are survival curves. If I had a normal blood pressure, if I start out with a normal blood pressure, 30 years later, I'm more likely to be alive if I can maintain a lower blood pressure level. If I have the more severe high blood pressures and stage 2 hypertension, I'm more likely to be dead. Nothing new there, nothing there. But what I think is a positive thing for this, you don't really see much of a differential. If I'm able to, in the first 5 to 10 years, 7 years, if I can get that high blood pressure to a normal blood pressure and get them under control in that time period, look at what I'm doing. I'm saving somebody's life. I'm doing exactly what the clinical trials are saying, and every study is telling me. If I get blood pressures down, the lower the blood pressure, the better I'm going to be with regards to my work. So we did a paper a couple of years ago called looking at the factors associated with a decline in stroke, and this is some wonderful people. Besides the first author, everybody's pretty good there. So looking at this, in 1970 there was a hypothetical put together by a group of epidemiologists, and they said, what if we shifted blood pressures to the left? What if we shifted the population blood pressures to the left? And they came up with this, and y'all have seen this, and it's been in many different guidelines and stuff. If you can just shift the population blood pressures to the left by 2 millimeters, however you want to do it, you can reduce stroke mortality by 6%. If I shift it by 5 millimeters, I can change stroke mortality by 14%. That map that I showed you in the very beginning, the Enigma of the Southeast, it goes away if this is true, if I can lower blood pressures that much. Well, now I'm going to be some more positives. You guys did it. You did it for everybody. You lowered blood pressures. This is looking at the shifts in blood pressure to the left. This is individuals 30 to 59 years of age. They shifted to the left, everything. So the lower blood pressures shifted to the left, probably with non-pharmacological, just lifestyle. The higher blood pressures, you treated, you shifted them to the left. Everybody all across the board, very, very significant shifts to the left. The 60 to 74-year-olds, the ones that we think about, they did the best because you guys did it. You treated everybody. Somebody walked in, they had high blood pressure, you treated them, you shifted them to the left. And how does that correspond? That corresponds with this significant reduction in stroke mortality in the United States. Look at when it began. It's been coming down all the time. And this is probably some treatment of the stroke, keeping people alive. Look what happened when we started in the 1970s when we said, blood pressure is something we can do something about. That's when we saw this acceleration of the blood pressures coming down, and it corresponded now with the reduction in population stroke mortality. This is a success story, maybe the success story for the century. This is something that you've actually done and maybe affected population health, and I believe global health as well. So this is about talking about target blood pressures. And so I just want to show a little bit of the evolution of systolic blood pressure. In the first two JNC reports, you basically had nothing at all about systolic blood pressure. It was just kind of lower blood pressures. And in JNC3, you began to look at isolated systolic blood pressure at about 160. That kind of corresponded with JNC4. JNC5 said, maybe we ought to lower it down to 140. Maybe that's the place that we ought to be thinking about, call that hypertension, start a treatment, and that's been corresponding all the way through. We then recognized with JNC7 the pre-hypertension category, in which you're probably going to treat individuals with you're not treat them, but treat them non-pharmacologically, get them to lose some weight. Showing it just in absolute numbers that a lot of people like to see. In 1960, the average systolic blood pressure for adult population in the United States was 131. In 2008, it was dropped down to 122. Exactly what that hypothetical example showed. Almost right spot on the equation, and predicting that we can actually do something that makes a big difference here. The question that still comes out, though, is thresholds. Again, the big issue that you do have, what are those thresholds that we'd like to do? We see different ones coming from different trials. We want to translate this into practice and make, what is that threshold for initiating therapy, and is that the same thing as your blood pressure goal? And that's the challenge, I think, that many people do have. So what are the issues that you're very, very much aware of? Why don't you just say the lower the better? I have some friends that look at me and say, oh, listening to you yak your mouth off, you would say everybody with the ideal blood pressure would be 0. And so we want to think, what can we do? And we're thinking about, if I'm going to lower blood pressure, I'm going to intensify the therapy. Well, some people have said to us, well, lowering the thresholds identify a larger population of people having hypertension. I got more sick people now because we've lowered the blood pressure, lowered blood pressure targets. And basically, these are going to be more people that are going to need therapy. It's going to actually double the number, if I go into some of these areas, double the number of people that we would be treating and bringing it through. It's one of them. Again, millions of people classified as hypertension based on higher blood pressure goals will require more drugs. We're looking at this, we're doing some global things now, and boy, this is what people are looking at. They're saying, hey, you know, what's wrong with 160, and let's get a start there. You know, we're not going to have, you'll eventually have everyone. Some people have said if you lower blood pressure too much, you bring in that J curve. I've lowered it too much, and I've got people that are having difficult. And also side effects. I've heard people say, well, I lower it too much and my older patients fall down and break their hip, and now I've got something else and this is it. And then basically right here, if it's neither harmful nor beneficial to lower the blood pressure at the targets, think of all the resources that we're basically wasting. And basically, again, the patient's adherence might be suffering too. So these are the counter arguments that we have to address if we're going to talk about lowering blood pressure. So let's talk a little about the lowering the blood pressure. This is some of the guidelines basically in treating people with hypertension and patients in coronary artery disease. So these are people that already have a disease that carry through. And I'll just tell you where we left that particular when I had the opportunity to participate in that group as well. And we looked at 140 over 90, and we're thinking this is probably good for most, but for the people that have coronary artery disease, we recommended that probably 130 over 80 would be the more realistic target blood pressure that we would want to go to actually turn around and treat. And I know that you're familiar. This is the JNC 8 guidelines, and I was very honored to be a part of that, and we felt like it was a very intensive evidence-based trial, and this is the recommendation that was the most controversial. And we looked at evidence, we graded the evidence, and we said, okay, if you're over 60 years of age, we recommend that systolic blood pressure, that's where the evidence is, a systolic blood pressure of 150. And I will agree that the evidence is extremely strong that 150, lowering it down there is very, very good. However, some of us felt like maybe we shouldn't have gone to 140, but we did. And when we did, we're seeing some great benefits. So we want something else to recognize that we don't quickly go up to 150 just simply because we think that there's been some very good, strong evidence there. So we're saying, okay, the corollary was that if you are if you've been treating to 140 and there's no harmful effects that you're seeing, go ahead and keep doing that. Some of us, 5 of us, did not feel that was strong enough, and so we wrote a companion paper, or what they refer to as the Minority Report, and this is basically saying that we felt like 140 over 90, the consequences of raising systolic blood pressure would be very, very high. And we based it on some of this information. These are data, and I imagine you've seen this before. This is from Lancet. And there's 2 pieces of this. This is looking at stroke mortality based on blood pressure, based on age group. And notice that for every age group, regardless of who you are, the higher your blood pressure, the greater your stroke mortality risk. Doesn't really matter. You can also use this, I think, as an education material too. So if a 50-year-old man walks into you and his systolic blood pressure is around 160, 170, you can tell that individual, you know, you're living like somebody 20 years younger than you are, simply because older than you are, simply because you don't control your blood pressure. So I think blood pressure is a big factor that's playing a role in here. Do we have evidence? You all have seen this, and so I'll go relatively quickly. Do we have evidence that says that almost every trial that goes in there, that's listed in here, show a benefit in stroke mortality, in preventing strokes and stroke mortality with a lower blood pressure? Nobody has shown that this is harmful. Nobody's even shown it's neutral. Lowering blood pressure for almost all the trials has shown that there's a benefit for lowering the blood pressure. Looking at it in a more intensive way, basically at every age, does it matter, we can lower blood pressure. And that's what this is showing. Yes, that almost every age group of adults, if you treat and lower blood pressure, including those individuals in the older category, treating and lowering blood pressure does indeed reduce the risk of stroke mortality, and that's what we're talking about. So one of the big trials that we do want to bring in that's kind of interesting, and looking at the ACCORD trial, and looking at cardiovascular disease, looking at cardiovascular deaths, the two primary things, but look at stroke in the ACCORD. ACCORD really didn't show a lot of benefit, significant benefit, for the more intensive blood pressure treatment. However, in stroke, the intensive blood pressure treatment stood out. It was really there. That intense blood pressure treatment was a very significant part of the ACCORD trial. What we waited for with JNC 8, which what it was called, or the panel from JNC 8, we were waiting for the SPRINT trial. Remember, we're looking for evidence. And this is kind of what saved us a little bit, some of us at least, on the minority report. As you know, the SPRINT trial was stopped, and it was stopped because of the great benefit that you were able to see with regards to intensive blood pressure treatment. They said that this is so intense, the Data Safety and Monitoring Board decided to end the trial, and end the trial early. But I want to bring up, and I bring it up in here, so there they stopped it, published the results, and everything looked great for most of the outcomes, with the exception of stroke. So we're saying, oh God, what's messing with us here? And one part of this is if you follow the trials and stuff, the trial was stopped early. There's a good sense, particularly with stroke, and a lot of the different trials, the stroke outcomes tend to occur later in the trial. And it's one of the last things that actually shows. And so that was one of the thoughts that we did have. And the other piece of it, looking at the other piece from SPRINT, if you looked at the outcomes, if you look at the side effects, excuse me, that's over there with intrinsic, a lot of those things that were brought up early, that we were going to see, that people were going to have a lot of adverse outcomes, really did not show up. It just did not show up that was a major thing. That doesn't take away from your need to practice individual medicine, but it does in patients. But at least the evidence did not show that there were a lot of adverse events. So kind of the conclusions from SPRINT was treating high-risk hypertension adults 50 years of age to a target of 120, significantly reduced cardiovascular mortality by 30% and reduced all-cause mortality by 25%. This was it. The trial was stopped early. And so there was a big thing. We were still concerned about stroke. And so I wanted to show this bringing in just a little bit more, looking at these variety of different types of stroke outcomes, and showing that SPRINT, the SPRINT trial didn't particularly show this outcome, and they showed it at least with the intensive treatment. So we bring all of this together and bring these studies together and show that combined with all of it, that indeed, as we look at this, if you can see, this basically is the last or this component right here, whereas SPRINT did not show a trial, but ACCORD did. If you put SPRINT and ACCORD together, which were very close to each other with regards to methodology, you did indeed see, when we combined those two together, we saw a benefit with regards to stroke. Looking at some others, these are some more recent meta-analysis, almost showing the exact same thing. Again, looking at the intensive treatment that we do see, and the benefit that you see all the way across the boards. And again, here is stroke, and we come across and we see a great benefit with regards to the meta-analysis and systematic reviews that we see. Another meta-analysis, again, looking at intensive blood pressure treatment, and again, we're seeing favoring on the favor of intensive blood pressure treatment, again, looking specifically at stroke outcomes in this recent Lancet meta-analysis. Again, the benefit that's here. I'm showing this over again because we want to see the evidence, and I think now the evidence is coming out to show that this might be bringing in a different view. Again, let me tell you one more time, from the meta-analysis, how about all of those side effects that would be from the more intensive use, showing this again, the ones that we think about, dizziness, severe hypotension, etc. Very, very, we're just not really seeing that those were the events, the things that would have happened and led to severe brains. Another part about lowering blood pressure, and this is another recent meta-analysis, and I know it's nothing more boring than looking at meta-analysis. This is showing, I think it's a really nice piece because it's saying we want to be intensive, but what's more important? Is it intensive going from 120 from 125, 130 from 135, etc. This is kind of showing that almost that basically, again, the lowering the blood pressure works at really any type of level. That falling in with that criteria, the lower the blood pressure, the better off we're going to, the better off that you will be. It's kind of a neat meta-analysis showing that, those kinds of things. Well, if I lower from 160 to 150 versus 150 to 140, et cetera, this meta-analysis is showing that all of those benefits, what you're doing, does show benefit to your particular patient. So can we do it? Can we do it? Are there some models that we can do it? This is some work from Kaiser Permanente, and basically it's miraculous. Can you do it with simple, and can you do it quickly? Or is this something that we're looking at over a long period of time, much like we've heard with a variety of other types of conditions? So this is what they did, and in one sense, what they did at Kaiser was took and basically looked at an evolution of a treatment algorithm, and kind of to simplify it, basically a fixed dose combination is the direction that they were suggesting that they wanted to go. The other pieces that they brought in, they did an annual quality goal targets. They used unblinded medical center performance reports, and so they shared those around. This is who's doing good. This is who's been bad, providing that feedback instead of just a grade. Looking at a central hypertension management team, they were kind of saying, who probably is the least qualified to measure blood pressure is the physician, and maybe we ought to think about others measuring that with white coat, with all kinds of other aspects of it. Let the physician do his or her job, and then we'll get someone else to take to measure the blood pressures and do it, and that will be their job. Thinking about, again, they formed these risk reduction teams. They brought in the best practices and showed those to everyone, and then they basically gave a lot of clinic feedback that carries through. Well, how did they do? Well, the first thing that they do is that their control rates brought up. Now, here is kind of the neat type of thing. So their control rates were here. They were not as good as national groups that are showing. Notice in just a very short period of time, they implemented this in starting like 2004. Look where they do it. They brought this in with just a simple protocol changes, just a simple difference in here, and bringing in some very good improvements. They had an internal grant. They said, well, maybe this is all select. Maybe we made a bad selection bias and we just selected the very best ones. This is showing you that wasn't the case. That what they were finding was real. That when they compared themselves to a real control, and this is where they kind of did. As you can see, their fixed dose combination of ACE and a diuretic. They kind of initiated in 2004. And notice they got those kinds of improvements in their blood pressure control in that short period of time when they were just initiating the problem. This is a tremendous success story that we can see. And let's see. And so again, their medical assistant blood pressure measurement checks, again, this allowed them to use their electronic health records. The medical assistant measurement reduced the white coat effect, almost eliminated it at that point. They had an enhanced compliance because of just the mere convenience, and it also enabled their primary care when the blood pressure was elevated to be outside. So this looked like a direction that they wanted to see. So the other key elements that were part of this, they had a hypertension registry so they could provide that type of feedback. They did a clinic level feedback, again, to tell everyone what's happening. They had regular meetings where they just talk about who's doing this and who's doing a little bit better. They did have some treatment algorithms that were very, very simple, easy to implement. They were not complicated in one sense like a lot of the algorithms are. They had the single pill combination pharmacotherapy, and then a good key part of this is they had their medical assistants doing the blood pressure checks. I want to show this because this is probably the take-home thing. This is probably it. So what did they do? We've already shown they've lowered blood pressure, they improved blood pressure control. Look what else they did. They had a 30% reduction in mortality from cardiovascular disease and a 42% reduction in mortality in their cohort from stroke. Really standing out. Isn't that what you want to say? I've lowered the blood pressures, now I want to be able to tell my patients that I've saved their lives. And this is what's happened. It's good to also notice that those were very dramatic changes that they didn't see. If you look at cancer, their cancer rates were almost right across the boards, doing some things certainly with cancer, but they showed the cardiovascular improvements with these interventions, which seem to be very simple and in one sense very, very cost effective that carries through. So summarizing that aspect of it, for the past 50 years, our goal blood pressures have come down, and subsequently you have followed through with that. You've lowered blood pressures on the population basis. We think that the sprint goals allow us to think about that lower blood pressure target, maybe into the 130, 80, that type of role. That's a good thing. And there's a number of good models that we're able to implement that we can actually show that have been successful in lowering. I wanted to hit on this too, because it's not the end of the question, right? So here comes somebody that's not hypertensive. What do you tell them? Lose some weight, get some exercise, and carrying through. We think that salt probably plays a big difference in where we are. And I show this because you think about it, because some of these, I don't know these answers. I know the answers now because I've got this slide, but we think about it. So if you ask me, so I'm your patient, I come in and I am hypertensive. So I come in to Dr. DrPh, and he says, why don't you eat more salads, Dan? You look like a guy that ought to eat more salads. And I put a big old smile on my face. I say, Dr. DrPh, guess what? I'm eating a salad. I'm eating salads. I eat salads all the time. I'm just doing so good. And he's saying my blood pressure's still high. And he's saying, you're eating salads? Are you eating much salt? And I'm going to tell him, no. So what do you think? So here's the Costco food court Caesar salad. Take a guess. C. Okay. Guess what? See, this is what's so great about this. Yes, that's right. I'm telling him I'm eating salad, so he thinks something else is wrong with me. Must have some kind of other problem. This is the level of salt that I'm turning around and eating, and I'm not reporting this back. And I think this is kind of do it. And if regardless of it, the World Hypertension League, we say 1,500 is what we want to go with, and I'll just go ahead and yield out 2,000 grams. Notice with this one salad, I've gone well over my daily quota of what you're thinking I should be getting. Who doesn't like P.F. Chang's? We all love P.F. Chang's. So here we are. So here I am, and I'm trying to tell Dr. Petty, once a week, Dr. DrPh, I eat at P.F. Chang's. I'm rewarding myself on Friday night. I go to P.F. Chang's, and I'm not getting too bad. I'm just having one meal. I'm having the double fried noodles with pork. Here are my salt. Take a guess what you think. B. Okay, that is right. Isn't that something right there? 4 days of worth of salt I'm getting on that one sandwich. It's good, but I'm not telling my doctor that this is what's happening. And then just to kind of leave it in here, everybody's favorite double cheeseburger. Most people eat 2 of these, by the way, right? You know, the guys come in, they eat 2 of them. So there it is. My salt is right there, and I'm able to kind of look. And y'all know these kinds of things. The idea is to try to get a little bit more of a message that maybe what's happening is that we're bringing in a little bit too much salt, and I think that can kind of live with it. I want to stop here. This is not a quick, easy fix. Hopefully we can kind of do it so it's not leaning up against the fat and getting the very quickest abs. I think it's more like we have to get out and we have to bring it all together. We bring you in, guidelines, evidence, and this kind of stuff, and make it more of the community part along with all the other helpful people that we can kind of bring it through there. With you, Dr. Petty. Thank you very much. Thank you. Okay. Dr. Petty said, suggests that the World Hypertension League, some of you may not have heard of it. World Hypertension League is an organization of organizations, and so all the members of all the hypertension societies around the world are part of the World Hypertension League, and we meet and we try to kind of coordinate. And if you are interested in anything that we're doing, we'd be happy to do it. We can even give you Journal of Clinical Hypertension as our journal. We'd like for you to have it, so if you tell me that you'd like to get it, you can get it for free. Just tell me. And now.
Thank you very much. Questions, thoughts?
I'll take it.
The hard part of giving this lecture, so I'm going to give a disclaimer also to Dr. Lackland.
Can I have both?
Is the guidelines are coming out the week after next.
That's right. That's perfect. 13th.
They're embargoed.
I have Dr.
I know the
Jackson, and
guidelines.
after Dr. Jackson will be
knows the
next.
guidelines, but we are absolutely strictly prohibited from talking about them. And that's a very, very difficult one.
Yeah.
But you might be able to do some innuendo.
Yes. And I think y'all can probably figure it out. I think you know kind of where we're going. Yes, sir.
Dr. Lackland, thanks for the talk. I'm at University of Tennessee, Memphis with Dr. Cushman, I think, who you probably worked with.
A very dear friend.
The quick question I had is, would you comment at all on, frailty and, lower blood pressure targets? Because I think that's also a common concern of, do I lower my blood pressure targets in individuals that are older and, on frailty scales?
It's a wonderful, wonderful question. And I think it's very, very common, and I think you see it too. And it's also brought up. And in general, if you look at long-term benefits, if you look at people over 80 years of age, which we're getting more of, and that's great, and that's great, it kind of goes back a little bit to your own clinical judgment. And because we just don't have the studies, maybe there'll be some coming out. If you look at the epidemiology, for people over 80 years of age, the lower blood pressures are associated with lower disease risk. Okay, there have been a few studies, as you know, that have shown some moderate benefit, but you also have then the other risk of what happens with the side effects. So, and I guess I think we're going to be okay, and I think people are going to be vague about that. So I think again it goes back to your individual judgment. If I'm 84, and I hope I will be one day, if I'm 84 and you think I'm living okay and I would benefit from that, I think you lower my blood pressure and carry it through there. If I look like I'm, and that's where that communication comes back, and I need to feed back to you and say, boy, I take these pills and I'm not feeling so good. It's a wonderful question, and there's just not a lot of clear evidence that's there. Don, did I cover that okay? That's right. Yes.
I'm not here to pick on P.F. Chang's, but I don't recall seeing those numbers on their menus. So my question is, what's being done on a national basis, whether it's FDA or another organization, to provide this information on menus when you do go to a restaurant? And secondly, I personally, when I go to a restaurant, I say no added salt, but for what that's worth.
Yes. I think we are doing better, and the impact. I hope that's going to be the impact. And I'll just share with me. I was at a ball game, and this was. New York was doing the labeling a little bit ahead of South Carolina. South Carolina is kind of like the more the merrier. Would you like a box of salt to go with your popcorn? And I was in line, and they had 4 types of popcorn that you could buy. You could buy the single, which is just popcorn with nothing. And then, and I thought, who wants that? And then they had popcorn with some salt and some butter, and then you had popcorn with one flavoring, and then you had the home run, which looked like wonderful. I thought, boy, if I could just have a home run. And it was popcorn with everything on it. Caramel and so just loaded up. And then I'm looking at, not only is it all the salt I would want for a week and a half, it's also all the calories that I would want for a week and a half, and I know it was good, but it had some impact. And so I got I ordered something else. I've noticed almost in all the places, fast food as well, it's there. Salt is not currently one of those things that's put up there for most of the meals. Calories is. So if you go to McDonald's, at least in South Carolina, and I imagine where y'all are too, some of the restaurant menus are not there. But you brought up, I think, the tremendous question. Can we trust these numbers? Are these really accurate that someone's actually gone out and said that this is the amount that's there? I think we will we're starting to kind of promote, because I think many people do, if I've lost some weight, so as I lost weight, my blood pressure came down. I think we're able to also show that same thing. If I reduce my salt intake, I think my blood pressure is going to come down, and I think as we start to incorporate more defined prescriptions, I think you'll see it being a little bit better. It's a tremendous question. You're spot on with everything.